So thank you for the committee for the opportunity to speak. It's been really insightful being able to attend over this past day. So I'm a clinical and research genetic counselor, and in these roles, I've had this tremendous opportunity to be involved in the consenting as well as the disclosure of genomic results to hundreds of research participants as well as to clinical patients. I have experience in returning diagnostic results related to the condition that the participant came to in both an adult and pediatric setting, as well as returning results or secondary results or results in which the participant doesn't have a known diagnosis or known family history. And this has primarily been through the Clinical Sequencing Exploratory Research Consortium, as well as soon it will be through the eMERGE Consortium as well. So I'm just going to focus this morning on genomic results because that's where my experience lies. I think we've heard repeatedly, and we've experienced in our work that participants want to know their results from research, and this is the case because they certainly do participate for some altruistic reasons, but there also is a component that participation means that they potentially could learn something, despite situations in which you have explained to them very repeatedly that their likelihood of directly benefiting from this research is relatively low. Participants are curious and they feel a sense of ownership over this information. It's their genetic information that you're generating information about, and they have the right to know this information as well. On the other hand, while many people do want to know this information, I think we need to be careful as we develop recommendations about how to return it and what to return. Clearly, early adopters of genomic research have indicated a desire to know a lot of information, all of the raw data if they could. And we have in some situations returned that. But as we continue down this pathway, there certainly are participants who don't want to know all of the information, and potentially they don't, and some of their choices are quite individual, in that there are many different factors that influence what they do or potentially don't want to know. And it might even seem a little bit idiosyncratic to clinicians in that they don't generally make choices that fit align the way we categorize things into severe or treatable or mild or untreatable. And rather, these choices often are influenced by things that have happened to them in their life, in their health, in their family's health, things that they read in the New York Times last week, and many different components that we are not measuring that influence these choices. But they're individual choices, and so clearly the strategy of one size or give everything back is not going to be the best option. The other thing that I think is going to be challenging is these delivery methods that we've heard already this morning. For the most part, the research that we've done, people have received the results in a very traditional setting whereby which they've had consenting with a geneticist and or a genetic counselor, had a very detailed discussion about what the research entails, what potentially they could learn from it, what type of results they might want to receive, and then the results have been disclosed in a similar fashion in these in-person sessions where we are allowed this incredible amounts of time to have a very careful discussion about what we know and what we don't know, the implications of the results, things about the degree of certainty of pathogenicity of a particular variant, the potential for reinterpretation, what do negative results mean for them, and all types of things. Unfortunately, or I'm not sure entirely unfortunately, this model is not going to be scalable to the number of genomic studies that are underway, both in cost as well as just the resources of genetic counselors. There simply are not enough of us, and they probably won't ever be. On the other hand, I'm not sure that this traditional method is necessary for everybody. So we're currently evaluating systems where we use research assistants who are trained by geneticists and genetic counselors to consent individuals to genomic studies. And participants at the same time have access to self-guided web-based platforms, or for those individuals who don't have access to internet, other educational printed materials. And at any point during this process, they also have this phone a genetic counselor option. So they always have the option to speak with a genetic counselor at any point during their participation. And we're also working on developing alternative methods to return results. The question is, can we responsibly return results using other methods that don't require a face-to-face interaction or even a real person in real time returning results to a participant, with always this option of having a real person available? These types of platforms are not entirely novel. They're being used in clinical settings, primarily by research or clinical laboratories that are doing large-scale carrier screening as well as direct-to-consumer. And I think there's some evidence to show that it does work for some. I just want to close on a couple of points. One is I don't think we fully understand the participants who will be receiving results. I think we really have, to some degree, only seen the early adopters of this information and I think we're still going to learn what it's like to truly return results to a very diverse population as we expand genomic research. So for example, this summer, I was inviting someone to be part of a genomic study, and she had not previously been in any part of genomic care or had any reason to come to the attention of genetics. And her response to me was, well, I'm not planning on committing a crime anytime soon. And this is because her initial link between genetics was not genetics and health, as we all go, but rather genetics and crime. And in the state of New York, anybody who commits a felony, we collect a DNA sample from them. So I think there's a lot of education that still needs to happen. And then finally, I think we need to be okay that there is going to be some level of misunderstanding. And rather than trying to eliminate all misunderstanding that patients or potentially other healthcare providers have about genomic information, we need to create more accessible pathways for participants and their healthcare providers to access information and find clarification when there is a misunderstanding. So I think this means that we as genetic experts need to make ourselves more accessible. We need to make the information available online, potentially more succinct, and kind of mushroom into more information as an individual needs it. So I think there are a lot of aspects that I think we're doing a thoughtful and good job so far, but there's a lot to make this scalable and make this available to the people who will be having results.
Thank you.